Hello and welcome to the Texas Mind Exchange podcast. My name is Cody Gould and I'll be your host. Today we were joined by Brad Nations of JB Advisors. We spoke about telehealth and the future of AI and its growing role in our day-to-day lives, as well as demystified health insurance. So without further ado, welcome to the Texas Mind Exchange. Just as a reminder, all statements expressed by our guest on this podcast are their own and should not be considered official views or opinions of myself or anyone else at Texas State University. Brad, thank you for joining us. We have had a great relationship. You and I have built a really great relationship over the past few years as you've kind of helped the Translational Health Research Center understand what's going on in mental health from an advisory perspective. And in ways that, enlighten or lighten up the vision of what's happening, outside the perspective that we might have. So the audience might not know who you are. So I would love to kind of start with your background and I guess your ties to the mental health world, because you're not a practicing mental health professional.
Nope.
So I would love to kind of like transition that and show people how we can have a lot of different roles rather than just being a clinician.
Yeah, happy to. And thanks for having me. I'm excited and return the comment. I've enjoyed this relationship and I've gotten as much out of it probably as y'all have on the other side. So yeah, really my background, is, to your point, fairly non-traditional probably when it comes towards mental health. Kind of came towards healthcare about 20 plus years ago after spending the first part of my career completely unrelated, more in operations. I actually graduated here at Texas State back in 1996 with a speech communications degree. So perfect starting place for impact on mental health. And really my first entry point kind of to this side of the world has really been in healthcare technology and digital health. So been lucky enough to be part of several organizations that started really, really tiny, all with very specific care delivery goals, ultimately to impact patient outcomes of all shapes and sizes, and been working on those for 20 plus years now. So everything from helping seniors find plans or healthcare plans that really kind of best suit their specific medical and prescription needs, helping patients or working with solutions that help patients find transparency data for healthcare and helping find high quality providers, working with organizations that work on second opinion services and both physical and mental support for a wide range of different conditions through remote help. And then most recently, I was on the executive team for a company called Folks Health, which focuses on gender affirming care and day-to-day primary care for the LGBTQ plus population. But in my current world, I run a small advisory firm called JB Advisory. And I work with a wide range of different early stage startups, many of which are in the mental health space. I work with health plans like insurance companies. I work with large employers and benefit platforms and a wide range of things. So while I'm physically based here in Central Texas, and a lot of the work I do here is certainly focused in this area, I also work really nationally and have a pretty good view on what's happening kind of across the country and maybe some unique care delivery models. And the last thing I mentioned, one of the best things I ever did about 3 or 4 years ago, went back to school and got a master's degree from the University of Texas at Austin for a master's of science in healthcare transformation, which really focused heavily on value-based care and health equity and how to think through some of the fundamental challenges that our existing healthcare system has in it and how to bust through some of those barriers to create non-traditional care delivery models.
Wow. Yeah, that's amazing. And I think that is a testament to the tides that have been shifting within healthcare 100%. In general. And I don't know if this is true. This is what comes to mind immediately for me. But COVID being the catalyst for a lot of stuff going online.
Yes.
Would you say that that's probably true, or was it happening before?
It was happening before for sure, but no question COVID really accelerated it. If nothing else, normalized it. So a couple things that are interesting. One is, telemedicine, if we just kind of subtract mental health for a moment, was certainly around before COVID for sure. But not a lot of folks used it. People preferred to go to traditional primary care or urgent care for more physical conditions, or go find a licensed counselor, a therapist, a psychologist, psychiatrist in a brick and mortar setting. That's kind of typically how we did it. But yeah, mental health in general wasn't being utilized near as much as it was as it began to be through COVID. And I think a couple things were true. I think one, clearly COVID is COVID, right? So we were all stuck at home. So There's a clear need on that side. I think the mental health impact of COVID, clearly, I don't need to throw out stats on that. It was impactful on all of us and continues to be, really reverberate. But one of the positives, if there is such a thing coming out of that, is I do think some of the emotional and social barriers around seeking mental health care really came down. I think for the first time probably in the history, at least in our country, is people were openly talking about needing and seeking therapy. And so it became much easier to feel okay about seeking it out. And so what ended up coming in behind that is our non-traditional providers. So you're seeing a huge lift in mental health providers coming into the digital side. So between 2021 and 2024, over $11 billion with a B dollars have been invested in digital mental health companies. And so these are organizations you may have heard of, like BetterHelp, Lyra, Spring, Calm, a wide range of organizations. And venture capitalists and private equity are actually pouring money into these types of organizations, which is awesome news for all of us because all it's doing is increasing access to care. Now, there's challenges with all of it, but you've seen a real rise on that. One of the interesting things that's happened, though, is on the backside of COVID, we actually are beginning to see some declining utilization, which is a challenge, and both in mental health, but also in physical health. Telemedicine, if you talk to most, say, large employers, health plans, or other groups that are offering telehealth services, almost all of them would tell you that utilization of the services has actually returned to pre-pandemic levels, which is kind of shocking, right? Mm-hmm. So with mental health, though, I'm hopeful that the through line, the general acceptance will continue on, and you are continuing to see investment dollars coming in. I'm an investor as well, and I invested just recently in a mental health company that unlocks domestic mental health companies, their ability to operate internationally. So imagine if you're an employer here in Texas, and most of your employees are here, yet you also have employees in other countries. You want to be able to provide mental health service for them too. So even at the international level, you're seeing investment dollars are being poured into companies like this to try to increase access to care. Now we'll talk about some of the challenges, but I'll pause there. But you're right, COVID had a huge impact.
Yeah, you were talking to some of the points I would love to get to. Yeah. So I think that's great. And I would love to also briefly go back to more private equity dollars going in, because this isn't a economy level podcast, but I do think that it is important for us to fully understand the spectrum of the money going in.
Sure.
And for mental health providers out there to get an understanding of like, why might some of these organizations be looking to purchase? Obviously, from a capitalist perspective, I'm sure it makes money, which is fine.
Sure.
But the increasing the ability for more people to get access to care, I think, is something that is a story that we might not hear. We just hear the money aspect of it.
Yeah, I think that's right. So, maybe take a step back and think about, how's healthcare or mental health care delivered in the United States? And it's typically going to come from a couple sources. So half of all Americans receive their health insurance and subsequently their mental health coverage through an employer. So 50% of this country gets their health insurance from an employer or some sort of a private entity like that. And maybe not just private. It could also be a public employer, a state, university, things like that. And then the rest tend to either, if they have access to healthcare, they're either purchasing it maybe through an exchange, but many of them are receiving healthcare through Medicare, through Medicaid, or other types of more government-funded or at least government-supplemented solutions. So, the question is, why would a venture capitalist or a private equity group care, right? So 100% you're right. This is a capitalist society. They are putting money in with hopes and intention of getting return, but they care because the demand is high. And so if you think about an employer, for example, so that's a world that I've worked with, for a lot of my career. I've worked with almost every major employer in the United States you can imagine. It's in some capacity. They want to see improved mental health of their employees for a variety of reasons. One, it's the right thing to do. And contrary to a lot of belief, most employers really do care about their employees and they want to see them do well. We also know, though, that mental health typically follows along other conditions. So there's other comorbidities, to use a medical term, which means that people that are dealing with mental health in many cases are also dealing with other challenges. And the reverse is true. So an easy example is a patient dealing maybe with obesity or a patient with diabetes likely also has a mental health component to their treatment. And so what employers will look at, and even broader government paying organizations, is it's not just a single silver bullet. If we just give someone access to a counselor, everything's going to be great. But there's other challenges that kind of go along those things. So how do you look at a patient kind of in a whole patient manner? And so it's not just maybe addressing someone who's dealing with obesity and helping them maybe think about diet or exercise or a GLP-1 drug or those types of things are out there, but also is there anything from a mental health perspective that's also driving behaviors, what is causing that? And so employers want to see healthier employees. Now, the more pessimistic view is they want them healthy because they want them at work, and that's okay, right? I mean, they do need them at work, but they also recognize that mental health is also the front door to a lot of other condition management, chronic condition management, and the payers of healthcare. And sometimes we use this term payer in healthcare, and it usually kind of brings up an insurance company in people's mind. But I would encourage you to unlock that or maybe toss that to the side. A payer of healthcare is whoever's actually paying in the end. So in the employer world, if you have a job with a company, they may have a Blue Cross Blue Shield of Texas, for example. The ultimate payer of that is likely your employer. Blue Cross Blue Shield of Texas might facilitate all the claims and the customer service, but your employer is ultimately paying the bill. I tell you all that because they really do want to see healthier, happier employees, but they also understand that mental health is not in a silo, and it can have impact on a wide range of other chronic conditions, which are really, really big money drivers and create very unhealthy patients. So I think when you think about why investment dollars are going in, they know that the demand is high. That's usually the answer to every question why something's investment. The demand is high from the purchase of healthcare, whether it be an employer or even within Medicare, Medicaid. Most of those solutions or most of those delivery mechanisms also have mental health components to them. And we can unpack, the growing trend of value-based care, which we can unpack that if you'd like down the road too, which is really aligning outcomes measurements to payments, which is awesome, which is where we want to head. But at the end of the day, this is why private equity and venture capitalists are pouring money. And even myself, why I invest in mental health companies is because we see an opportunity to try to improve access to care, but the tail to it is really long.
Yeah. Thank you for that. I think that's a really great description for something that seems so foreign to so many of us, because I feel as though at least some of the mental health providers that I talk with, especially when I'm in class, I feel like I've told you this, but I'm in class to be a licensed professional counselor, licensed marriage and family therapist. It's not something that we really talk about. So it's kind of part of the story of mental health that exists, and it's blazing a trail forward. But for those of us who are looking to provide care, we don't really understand it. At least from my perspective, we don't talk about it in school that much. We don't talk about it at an academic level. So thank you for kind of opening up that door, because I think it's a really important part of understanding the spectrum of how mental health care is going to continue to grow. Because if there isn't investment put into it, then it's going to stay stagnant.
Yeah,
at least that's the perspective that I see.
And I would throw to you too, as you're seeking, in your career, the one beauty of this too is it opens up a huge amount of opportunity for folks like yourselves or for providers, right? So you think about traditionally, I live in San Marcos, Texas. The pool in which I can kind of swim in here and try to attract patients is San Marcos, Texas, or some radius that people might be willing to drive. And you'll find, based on the scarcity of the subspecialty, that was a tongue twister, people's willingness to drive is longer, right? So, but if there's a lot of mental health providers, say here in San Marcos, and you're trying to think about, I want to build a practice, you really want to help people, in the old world, this is kind of your universe right here. But with this access to digital health and the telemedicine, you now could actually expand your services inside the state of Texas, outside the state of Texas with proper licensing and credentials. And so it not only opens up access for patients, but for providers, it gives them a much larger pool of patients. And then the really amazing thing is, and we can unpack this if you like too, is then you drill down into subsegments of patients, right? So not all patients are the same, and not all providers are the same. And sometimes a wonderful provider might not be the right provider for every single patient that's out there. And so you really then allow for culturally competent care. You allow for better alignment between what the patient might need and what the provider is able to provide. So you'll have an amazing education, you'll have a great background. But if you're trying to serve someone where your life experience is so radically different than theirs, you may have some trouble connecting at times. Not saying you can't provide value to them. An example would be I mentioned the company Folks Health that I work with. Folks in the LGBTQ plus population. I'm the father of a child in that community. There's a significant mental health need in that community for sure, but also a massive shortage. 60% of Texans inside that community will tell you that they would like to seek care, but they're not, either from lack of access, for fear, or lack of providers who actually can provide any relevant lived experience. So If you're gay, if you're trans, if you're, and you want to seek care, if possible, finding a provider that actually has experience, either lived or professional, would be hugely helpful. 30%, I believe 30% of all Texans are Hispanic, but 80% of providers in the state are white. And again, there's nothing wrong with having different types of experiences, but the idea is over time, can you create more culturally aligned providers to mirror the patients that they serve? And by allowing remote access and allowing you to serve maybe outside of your local area or your local state, you can really open that up. So there's an opportunity for both providers and the patients in this scenario by allowing that.
Mm-hmm. Yeah, I think that's really well said, and again, continues to open up the perspective of how we can continue to adapt to the changing winds of mental health care and not just work within that radius that you live within. And how can you expand your reach outside of that and do it virtually? Because I think that's obviously the future. And that leads me to ask a little bit about your past and organizations that you've worked with and kind of what you've seen work well or trends that you see coming down the pike. You work on in an advisory perspective. You also have sat on boards, I believe.
Mm-hmm. I do.
Are there trends that you see that are very positive that are coming down the pike that we might not really know of at the moment?
I do. I think there are a lot of trends. The first is just what we touched on, which is just general access to care.
Mm-hmm.
But I think what we're seeing more and more focus in on value-based care, which I think I mentioned a moment ago. And the idea of value-based care, for those who aren't familiar with the concept, is how can you align, or let me back up. How can you actually focus specifically on patient outcomes? So in many cases, you think about other services we seek out in our world away from medical. And there's an expectation that if I give you money that you're going to provide a service and that service will be rendered and we're good to go. My car's fixed. My TV works now. My internet is running. In healthcare, though, in many cases, we don't have any kind of measurement like that. And there's no recourse either. So I might go seek services. I might have a surgery. I might seek therapy. It might be mental health. But there's really, in many cases, no measure to determine, am I actually improving as a patient? And then if you tie it back to compensation and to how we actually incent those behaviors, healthcare is one of the few things in this country where the incentives are not necessarily aligned with the outcomes, right? So a clinician or provider might get paid whether their patient gets healthy or not, right? You can try out a million different things, but ultimately the outcomes for the patient themselves is the most important thing. And I'm seeing a big focus on that now. It's been around forever. And the idea is, there's a term we use in healthcare called the intersection of cost and quality, where the idea is if you incent good outcomes, you're likely to get better outcomes, right? If you're a clinician, and if I'm a mental health provider and I'm dealing with a patient with anxiety or depression, and I'm, when my patient first comes in, they'll do a PHQ-9 or a GAD-7, something to assess my baseline. And over the course of time, we want to measure over and over again. And hopefully, those numbers are improving and I'm getting better and better. Well, imagine a day where the compensation also has some alignment to that. The incentives are there. So maybe I'm a provider. I want to be incented to make my patient healthier, right? If you subtract mental health for a moment, one of the core challenges we have in this country is what we call fee for service. And you're probably familiar with that term. But the idea is, again, back to misaligned incentives. The medical community is actually incented to do more stuff to us, but there's no real accountability on the outcome side. But a clinician, and not, most are truly in it for the right reasons, but you are incented to do stuff because they generate fees and they generate revenue back to a practice. But you're seeing more of a change to more value-based care, which is focused on how can you align the outcomes of the patient back to the incentives that the provider has every right to claim, right? Providers need to make money and need to be able to make a living as well. But we want to make sure that everyone is aligned on the goal, and the goal is healthier patients. And so what does that mean? Well, that means a lot of things. So the great thing about mental health is, anxiety and depression, for example, is an epidemic, right? And definitely post-COVID. And you can unpack social media, you can unpack phones, unpack all the things, but it's impacting all of us. And so, but the nice thing with those is that there are some great measures and some universally accepted measures. I mentioned the PHQ and the GAD, other types of mental health challenges. There's other measurements there. And then there's also really well-established interventions, right? So cognitive behavioral therapy is something that is, continues to be utilized more and more and more. It's actually the foundation of a lot of those digital health programs. And so you have things that can be done that are evidence-based that will allow people to actually seek or move forward. But imagine a day where you can actually then align payments back to the success. So my PHQ-9 score was this, and now when I'm done, it's over here. That provider could actually be rewarded for that, therefore then incented to try to help get me to a healthier place. And then the next thing down is really also looking then at more patient-reported outcomes. We're starting to see that get utilized more and more, not just in mental health, but in all of healthcare. And so what that means is that means sometimes taking away from like a well-established measurement like a PHQ-9 and actually listening to the patient themselves. So if I'm sitting down in a mental health provider, you can do some formalized testing and you can see my progress that side. But a lot of it also just listen to patients and what their particular goals are and then measuring against those goals themselves. And so we're seeing a nice trend where payment models are starting to revolve around those outcomes. More and more and more. You see it with Medicare and Medicaid, which is good. You're seeing it more on the private side as well. You're seeing lots of employers, and you're seeing a lot of these digital health groups are saying, hey, we want to actually be incented for helping cure patients or at least see better outcomes. So that part I'm finding to be really, really positive. And again, it's a trend that's been around for a long time, but it's starting to get a lot more traction now. And I'm seeing the larger payers of healthcare, employers, health plans, et cetera, are really starting to pay more and more attention to it. And that's actually some of the work that we do. The group that I work with every day is helping groups kind of think through that piece.
Yeah. The theme that I picked up from there is incentives are good.
Yep.
I guess on the flip side, is there any potential challenges that come with strictly following the incentive-based therapy? Because I think that sometimes my immediate response goes to, well, what happens if somebody doesn't fit within the certain confines of what the incentive structure is?
Yep.
Or if somebody might need a lot more help or a lot less help? Am I, as a provider, going to be rewarded or have my wrist slapped by not following that structure to a T?
Yeah. Great question.
Is that something that I guess comes up on your end when you think through what the future of incentive-based therapy or incentive-based care could look like?
It does. It's a great insight, and there the sad part / opportunity is there's no silver bullet there. Just because someone's PHQ-9 got better, maybe doesn't mean there's not other challenges that exist, right? And so in the end, I think a couple ways to think about that. One, it is surrounded around the patient-reported outcomes piece. I think we call them PROMs. In the end, those are, it's hard to tie incentive payments to them, but they are an important part of how's a patient feeling about the care that they received. How are they feeling about the outcomes that they've achieved? The master's program I did at the University of Texas, led by an amazing woman named Dr. Elizabeth Teisberg, who's one of the pioneers in this space. She has a framework she calls capability, comfort, and calm, and kind of thinking through the care that we provide to our patients through the lens of those three categories: capability, comfort, and calm. And you can kind of break those down across any bit of healthcare. But when mental health, I do think it's especially important recognizing that, not all patients are the same. Not all interventions are going to be the same. So you as a provider do have to have the flexibility to be able to figure out, okay, for this specific patient, maybe a CBT pathway is the way to go. Maybe it's a different type, more intensive therapy, but also giving you the freedom to think outside the box on, maybe they're a completely unique type of care delivery. Because otherwise we just kind of created this robotic way to seek care, and not all patients are the same. Not all patient segments are the same. Not all patients' comorbidities are the same, right? So I might be dealing with this, but also 9 other things that are totally different than your 9 other things along the way. So I think that is a positive thing we'll think about. The other thing we see, in part of this change over to a value-based type model is what we call capitated payments, if you're familiar with that type of term. Or sometimes you'll hear maybe a bundled payment concept. But the basic idea is this, is you take me on as a patient and there's X amount of dollars are allocated to you as a provider, and that's the cap. That's how much you're going to receive. But how you choose to treat me in the middle of that is really kind of on you. Now, you're now very incentive to keep me healthy and get me right. Otherwise, I'm going to be a real burden to your practice, and I'm going to be constantly seeking services. But what you're starting to see is groups that are willing to take that on are also finding non-traditional ways to deliver care. So I'll give you a good example. One of the case studies we studied in the UT program was on the Commonwealth Care Alliance out of Massachusetts. And they were in a capitated type of model. They dealt with patients in the Medicare and Medicaid space. A longer story, and actually they have an interesting story if you research now. They're actually, at the moment, dealing with some financial challenges. But they really were pioneers in thinking about, what are some unique ways in which we can address mental health challenges for this group? We're going to get paid the same amount, but one of our goals is we want to keep them out of the emergency room, out of urgent care, and also help address chronic challenges. Well, they know so much of that is tied back to mental health. So they were doing things which are totally non-traditional. For example, they had a patient, the example they used was she was really missing community, right? Which we know is one of the just foundational aspects as humans we need for our mental health. And one of the reasons why she didn't want to go outside and visit with her neighbors is because she didn't like the way she looked. She was worried about she couldn't afford to dye her hair or to put makeup on. So as part of their care delivery model, they actually went and dyed her hair. They helped her with that in home, so she felt confident to walk outside and be with her friends in her community. Now, is that a traditional mental health protocol? Absolutely not. But in a model like that, it actually gives you some flexibility as a provider. But if you were in a traditional fee-for-service world, there's no code you can file for hair dye, right? So in the end, the idea is, I think, as providers, we need to create a platform for you to get creative. You want to always live, within evidence base, but at the same time, as evidence base was created on new ideas, right? So over time, we want to be flexible, but the incentives and the payment models need to align with that. Providers have every right to make a living and feed their families and run a practice. And so it is a bit of a learning. One last thing I will throw in, just on the trend side of things, we're also seeing the merging of mental health services with a wide range of other types of services. And so what I mean by that is, in the digital health space, if you're an organization, just to kind of keep maybe with an obesity timeline, if you're an organization, one of my clients is a company that deals in the cardiometabolic space. So they work with patients dealing with type 2 diabetes, dealing with weight loss or weight, or just overall a healthier lifestyle. But they clearly recognize there's a mental health component on that. So you're seeing solutions that maybe were originally just focused on cardiometabolic, but also going, we really need to also have a mental health component of this. So part of their treatment model is not just, hey, here's a better diet, here's a GLP-1 for you, but also let's get you connected to a therapist or to a counselor, to a social worker, someone that can help you think through the whole patient. And we're seeing a really nice trend as well in the area called what they call advanced primary care. So this is a space I do a lot of work in. And advanced primary care is a model that takes a wide range of services and puts them all into one room. Again, in this kind of capitated, non-fee-for-service model. So sorry if this is too nerdy on the funding stuff, but and so a great example of that is HEB. Those of y'all that are listening to this podcast that live in Texas know exactly who HEB is, and those of you that don't, they're a grocery store chain, the largest private employer in Texas, and one of my clients. And what they do is they created a series of clinics in this advanced primary care concept, where they don't do any insurance billing. It's not a fee-for-service model, but they collapse a wide range of services into one place, which include unlimited primary care, labs, physical therapy, dietitian services, care coordination with specialists, and mental health. And so all those things are together in one roof. And spoiler alert, that covers about 85% of most of our day-to-day needs we have for healthcare. And it increases engagement with patients. Overall patient satisfaction is better. And you have an integrated care team that is thinking through every aspect of my health. So it's not like I see my physical doctor for my PT, then I go across the street to my mental health provider who has no knowledge of what's happening on the physical side, and everything works in silos. It brings it all in place. Yeah. And so that's a trend that's happening more and more as well. Employers are starting to put solutions like that in. Other types of organizations start to look at these advanced primary care concepts, and they're all over the country. HEB just happens to run one of the best in the country, and it happens to be here in Central Texas. But anyway, I'll pause there. But yeah, a lot of trends having that way, but mental health not only as a standalone, but also as woven into other solutions.
Yes. And I think that's the biggest thing that I'm seeing as a trend that we talk about in class and that I hear from you, is having everything under one roof is the way of the future. And whether that's online or integrated with partially online and in person or what have you.
100%.
Because I also think that we see that trend from a nonprofit perspective, or a community level, community-based level, I guess, implementation of it when it comes to potentially helping the homeless community or the unhoused community. They already have, there are centers, at least I know of in Austin, that are popping up that have similar types of a wide spectrum of care under one roof. ideally. And
Yes.
that's kind of what the goal seems to be happening. And so to, I guess, expand that out into like quote unquote the general public makes a lot of sense for somebody to go to physical therapy and mental health and get their blood drawn and so on and so forth. So that's a really interesting trend that I think that will hopefully continue to gather steam.
Yeah, I think this concept of an integrated care team or integrated care unit is not a foreign one to medicine, but it's starting to expand where you're bringing in lots of specialists in one place. The financial models are the challenge, though. Is like, how do you make sure you cover off all those services in a way that is paid for by whatever the funding source is? So it's not easy, and it is great in theory, but in practice, it can be really challenging on that side. But I think finding those, and like you mentioned, say in an unhoused population, again, a very unique segment of folks, right? That is very different than maybe a segment of employed people or people, living in a different part of the country. And so being able to be flexible within the populations you served, you'll see accountable care organizations or ACOs, have been around since ACA passed several years ago. And they're trying to solve the same problems, right? Which is, here is the segment of patients that we're serving. How can we best serve them within the financial model that works? And how can we get creative? And that's where some of these, non-traditional care delivery models I've been talking about today are really starting to get woven in. So if I'm, dealing with a mental health solution or challenge, but I know that it's a 6-month wait to find a local provider in my area, which is not abnormal, but I can, in 2 days, I can be on with a provider from BetterHelp or from Calm or from Spring or from Lyra or any of these groups. Is it as effective as brick and mortar? It may very well be for whatever you're dealing with. Is brick and mortar a better option for some patients? Absolutely. And so in many cases, it ends up being a both and scenario. And so helping people either address it through the modality that makes the most sense for them, but also our needs change. I've several times in my life, I've sought therapy, right? And in many cases, a virtual works great. Sometimes it's just a refresher on CBT. I need to get myself back in mindfulness and breathing techniques and things to help control the anxiety that I deal with. But there's other times like I need to sit in a room with somebody and I want to do that. And so, I run the same access problem as anybody else does. It might be a long wait. There may not be a provider in my area. But in many cases, it's a both and solution, but a lot of times bespoke to a patient segment, right? And I think that is part of the things we have to do in the healthcare medical community is continue to work to find patient segments and like, patients with similar needs and find ways to kind of treat them. Because what we don't want to do is force the patient to be the navigator of their own care. We don't want them to try to figure out, I don't know where to go next, because guess what? They'll do nothing. Yeah. And in many cases, we all suffer in that scenario. So if you notice the trend I'm talking about, it is a lot about focusing on the patient outcomes, collapsing services, but ultimately trying to help somebody really hold the hand of the patient and provide multiple services, maybe in single locations, or at least help navigate to the next appropriate one, and try to think about the patient less on a condition by condition basis, but more of a whole patient aspect. And mental health is the one through line that runs through every single condition we deal with. No matter what it is, there's a mental health component to it.
Absolutely. Yeah. And I would love to transition to something I feel as though you are an expert on more than anyone else who we've talked to and probably will talk to. And that is the integration of the future of mental health and AI. And I think a lot of people are scared of it, including myself. And also it's an inevitable thing that's coming down.
Yes.
And it's going to be implemented in almost every part of the way that we look at healthcare, the way that we operate on a daily basis. So from your perspective, what do you see kind of is the future of AI as it pertains to mental health and maybe health in general? Yeah,
boy, it is everywhere for sure. So I probably talk to 2 to 3 different founders a week these days, and not just mental health, but across healthcare.
Wow.
So if nothing else, that shows you, just that. I mean, I'm a very small part of this community, and kind of gives you a sense of the volume of founders that are out there coming up with amazing ideas. But every single idea that's being invented today has AI wrapped all within it. So mental health or not. So yes, 100% right. It's going to be, it already is. I mentioned a company that I just invested in recently, this organization named Trova Health, and what Trova will do, the way that they can enable, say, international mental health care, and they can do it at scale, is AI, right? If you think about their ability to go into, say, 20 countries next year, identify providers that that are available, that are willing to serve, that kind of meet certain criteria, understanding, say, a country or even state by state laws and requirements, which, by the way, are changing on a very regular basis. Understanding currency conversions, time zone conversions, all these types of things in the past would have required analysts upon analysts upon analysts, and would have taken a long time. With AI, you can actually scale these organizations very, very quickly to utilize that data. So if you take it back to the United States, as mental health providers, especially those kind of cutting across state borders, they have individual people whose job it is to constantly follow what's happening in each state. As we sit here right now, the Texas legislature is in session. So there's lots of bills that are being thought through right now, and some will pass that have a direct impact on mental health for a wide range of Texans, and the same thing at the national level. It's very difficult for any organization to keep their eye on and tabs on all those types of things. AI enables faster data integration, changes recommendations, et cetera. So just at a core business level, it's allowing organizations to scale faster and cheaper, which is a very positive thing, right? Especially as we're trying to knock down access to care issues, AI is going to help really speed a lot of that up along the way. From a care perspective, again, being woven in almost everything you can imagine. So I talked to a founder recently who's working on a solution. It's out of MIT, and it's not a mental health. It's not meant to ever replace a mental health provider, but it ends up being almost a companion of sorts. And these are things we've seen in movies for years and years and years. And but the example would be, this would be a bespoke, personalized AI companion to me that is really focused on my mental health. And it's not just like creating large language models and dialogue, which you can do, and it can learn you. So an example would be, if it gets to know me, and after a few weeks, it's like, oh, Brad, you mentioned your mom's going to the hospital. How's she doing? Thanks for asking. Here's what's going on. Oh gosh, that sounds scary. But just to be able to kind of have a dialogue, because loneliness is a massive epidemic in this country that we know, and AI is going to play some semblance of role in that. But what we'll also then see as kind of the next steps is, it can also then help to direct people towards more traditional care and providers, right? So maybe I'm just having a rough day and I just want to talk to somebody. There's no one to talk to. An AI companion, as futuristic as that sounds, that's actually here, right? And it actually can create comfort for people to be able to have that. But by the way, if I'm exhibiting other types of challenges, it can then begin to direct me to the appropriate care. Hey, Brad, you work for XYZ company. Hey, don't forget, they've got an employee assistance program, which has access to mental health. I actually have the list of 3 providers here right now. Oh, and I can actually see that 2 of them have availability next week. Do you want me to go ahead and schedule an appointment for you? Like, that's AI, right? Mm-hmm. I mean, who would have done that in the past? And here's where it gets even crazier and cooler in some capacities, is that it also can measure other types of things, not just what we say, but how we say it. The voice, hesitancy, it could actually, it's getting to the point where if you had a video component, it can actually look at nonverbals. And so it can assess emotion more and more to be able to, again, look at you and say, Cody, you said you're doing fine, but something seems off. Can we talk a little bit more? Or you seem upset. You look upset, and it's starting to interact more in a human manner. And again, it's terrifying as it may sound on one hand, considering the fundamental shortage we have. And sometimes people just are nervous to talk about things with other people. It can actually unlock folks' ability to go seek services from professionals like you, or potentially even just drive towards CBT models or other types of therapy. So I do see it as a positive. One last thing I'll mention, because there's a million, is also as diagnostic ride-along tools for providers, right? So if you think about in medicine today, there's a stat I heard a long time ago that don't ask me to cite it, but you'll get the general sense is, there's an evidence-based treatment, say, for 80% of conditions in the world, but it's only followed about 40% of the time. So some version of those data points are accurate. But the idea is that it's impossible for providers of all shapes and sizes to stay on top of every single trend for every single thing. Think about everything a primary care provider has to take in. Right. So ride-along tools with AI can actually be in the room listening to the conversation, and in real time giving a doc recommendation. Hey, Brad said he's got XYZ going on. I know it probably seems like this, but those 3 conditions sometimes actually lead to this other diagnosis. Let's take a look at that, versus relying on that provider. So it makes the provider stronger as well. In a mental health perspective, it could be making recommendations on care pathways. So you mentioned as a provider, not want to be locked in too much, and it doesn't put too many restrictions. Well, AI could actually unlock it and say, hey, Cody, you know what? Actually, I just like in real time could say, hey, there's 5 studies out of California that said for this type of patient, this is the most up-to-date evidence-based way to treat that. And maybe just be something you haven't had time to read about yet. And so I think on that end, it's going to fundamentally change things for sure. Now we can unpack privacy and Big Brother and all those things all day long, and as well we should. But I do think from an opportunity perspective, it opens up a lot of really interesting aspects, especially around mental health.
Yeah, it seems as though the theme that I'm picking up on is speed to care and speed of care being able to increase tremendously while folding in these AI tools. Because as of right now, it could just go at whatever pace both the client and the provider are used to. Whereas if you fold in AI, depending on how you do it, it could give you quote unquote answers or suggestions or potential paths forward a lot faster. And that's really important. But you said something earlier that I would like to talk about as well, which is the shortage of care. And with your background and working with a lot of these businesses, there obviously seems to be a shortage of care. What do you think is the reason for that, as well as what can we do as a community to enhance, to alleviate that shortage of care as much as we possibly can?
Yeah, it's a great question. So taking what's causing it first, like I don't have great data in front of me on, I hear about shortages of providers in general, just a math problem.
Yeah.
So are there less and less people going into it? And you probably know more about that than I would. But I would say back to what we, at the top of the discussion, which is, the positive thing about this is that the acceptance of seeking care is at an all-time high. So I think more and more of us are going, oh, you know what? I think I need to go see somebody. Whereas before, maybe we swallow it and suck it up. Maybe we drink our way through it. Maybe we take drugs to get through it. We seek other types of things, or a lot of times non-healthy behaviors. So I do think for the first time, really in the history, at least in the United States, folks everywhere are saying, hey, I think I need to seek help. And so I do think the demand has gone up. The pandemic clearly had an impact on it. Regardless of your beliefs on social media, on phones, all that, there's the data's there. Like these are damaging tools to us. I personally, and again, this is easy for a 52-year-old guy probably to dial back from social media, but I found it just was not a healthy thing for me. It created anxiety for me. So as I think about ways I can reduce my own anxiety, that was one of the things I cut back on. But that's not going anywhere. Like that's not the solution. So in the end, I do think there's more demand than there is supply, which is just a fundamental economic problem. Hence, $11 billion in 3 years being invested. So back to finance, right? It's very simple how that stuff works out. But I do think, as we think about the ways we solve it, you're seeing everything we've been talking about here. So not to rehash, but so through non-traditional care, through virtual care, I think through rural communities for sure. Here in Texas, we have lots and lots and lots of rural areas and remote areas. I think it's 98% of Texas counties are considered in a shortage of mental health providers, the last study I saw. Yeah. So that's not getting fixed anytime soon. Doesn't matter however fast you can get to market, you're going to be just a small part of the solution. But we also have, we have cities where we have more providers. So can we give access to rural areas to those providers? So the digital solutions help there too. Two things that hit my brain. One is also kind of seeking out care delivery that maybe is not as formal as we think. So, and what I mean by that are, peer-to-peer, faith-based organizations, community organizations, support groups, seeking out more and more things more and more groups of people that match my segment and my lived experience. I'll give you a personal example. Over the last year, I've developed a vestibular disorder. So I've become a dizzy person. It's a very rare thing, but it happens, and trying to figure out a physical way to deal with it, but it's not going great. And it drives a lot of anxiety for me. And at times, frankly, depression. Like, is this how I'm going to feel the rest of my life? And so, while seeking out things like CBT and or cognitive behavioral therapy and traditional pathways, of course, but joining support groups of patients with similar types of experiences I'm dealing with has helped me probably more than anything else, because you can sit back and think, oh, I'm the only person in the world dealing with this. And then you get online or you go to a meeting and you're like, holy cow, there's people everywhere dealing with this exact same scenario I am. And so I think people seeking, and we're seeing more and more of that, support groups have always been around, but peer-to-peer support. We're seeing a lot of platforms get created to bring people together with similar types of health conditions or social situations, gender identity, sexual orientation, all those types of things, and putting you in a room with people that are like-minded or have same lived experiences is a very, very rewarding thing and helps overall mental health. So I think as people seek out things that are not just therapy or not just the brick and mortar we think of, I do think that's a way in which we can continue to solve for that. And we're seeing it both digitally, but also in person. But think about, even I live in San Antonio, big city. There's actually no in-person resource for people dealing with the kind of condition I deal with. Now I could drive to Houston or Dallas or Austin, or I can get online and talk to people from across the country, right? But oh my gosh, I'm so glad it exists, because 20 years ago, I'm just kind of sitting in it, feeling bad about myself.
Yeah.
So I do think on that end, one last thing I'll mention, which is kind of a far-flung idea, but it's top of mind for me lately. And mostly because of the work I'm doing, starting to do internationally, is what's kind of fascinating is we know we have a fundamental shortage of providers here in the United States. And we talked about all the ways we're trying to solve for that, but it still hasn't fixed it. But you also have other countries who have providers who have availability. And so imagine a scenario where you potentially actually unlock international borders and allow providers from other countries to serve patients in the United States. Now it opens up a million questions, on training, on background, on privacy, on HIPAA, on data storage, et cetera. But we could look at a scenario at some point, and this part probably gives a lot of people chills, but where you could actually expand out the support. Because today, people in the United States actually do seek care from folks outside the United States, just not in the more traditional, like in therapy and counseling. But you could potentially actually open up, and a therapist in London has 4 free hours this week, and a patient in Tulsa, Oklahoma could really use those hours, right? Could you potentially actually eventually cross? And that's something to think about for the future. And, there's a lot of laws that prevent that from happening today, and will stay in place, but there's a lot of ways we can skin this thing, is the idea.
Yeah. So it's fascinating to hear your perspective on the future of what this can look like, because as of right now, anything could happen. And we could continue down this path of what's happening right now, meaning, there are LPCs, LMFTs, social workers, things along those lines. But also there's creative new ways of primary care, or different types of peer support, or folding everyone underneath one roof, or expanding the borders. There is such, at least what I hear from you, is that there is such a dynamic perspective of understanding that there is a clear problem, which is mental health needs more help. And the solution is, we're going to figure it out eventually. And so I think that is interesting. And from an advisory perspective, as somebody who talks with a lot of these founders, or talks with a lot of these organizations that are investing in mental health, do you predominantly find, you mentioned AI, that you're kind of working with a lot of AI organizations, but do you see a lot of similar themes with a lot of these newer organizations that are popping up, or are they all in their own lane as it pertains to how they want to help their potential clients?
Well, that's a great question. I think they're all in their own lane. It's so funny. Like, we use AI like this, like it's a thing.
Yeah.
We talk about like it's a singular entity.
I don't know.
But it's so customizable.
Yeah.
So I would say, I'm going to answer your question in 2 ways. One is kind of at the macro level, there's a lot of overlap, tons and tons and tons of overlap. Like I talk to all these founders, and almost every time I'm like, oh, I've already heard this.
Okay.
But then when you get down to the micro level and understand like their specific approach to it, you're like, oh, okay, I see where you're coming from. That's different. And so then the next thing I do is, especially if this is a group that's paying me, most of the time it's just conversations of groups that are trying to get off the ground. But then my fiduciary back to them is to challenge, so the sad truth, this is the part, especially I think on a lot of providers that maybe aren't the business side, don't want to have to think about. But the first question I always ask is, who's going to pay for this? And you have to figure that part out, because without it, no one's going to give you money. A VC or private equity group is not going to fund your idea if they don't think you have someone to sell it to down the road. Right. So that takes the wind out of a lot of people's sails, and it's a bummer, but it's just the truth. And you're seeing more and more reduction, say in federal funding, reduction in state funding, reduction in other areas. So then you're left to who's going to pay for it. Well, is it going to be a university? Is it going to be a nonprofit? Is it going to be a foundation? But you're going to have somebody that's going to fund it because there's legitimate things have to be done, and the founders need to be fed, need to be sheltered, and all those types of things too. So if you can solve that problem, so a lot of the work that I do is help people think through who an audience might be that would find value to this. And then you're back to why would someone buy it to begin with? And, it's some of the things we've unpacked today is, they have, if it's mental health, they have a clear problem that needs to be solved with a group of people they're representing. We think this can do that. If they don't see that, these things are not going to get off the ground. And you'll find in categories, only a handful are going to win because the market has a hard time discerning, the microscopic differences between organizations. They just kind of want to know which one is generally the best one, and I'll go grab that one and put it in. And so it's a lot of the work that we do is helping purchasers of healthcare services understand those microscopic differences. But then also the other piece I do want to stress here for anyone that's thinking about creating something new, or even for yourself that's entering this space is how are you going to think about outcomes measurements from the very beginning? And too many times we get excited about the thing we're creating and the methodology on how, or the logistics side of how we're going to deliver this care, or what's the intervention going to be, but we don't put enough time in the measurement of the actual impact to the patient. And what happens all the time, and I've seen this for 20 straight years now, and it will continue through my lifetime, is people invent some really cool stuff. And then they take it out and they actually sell it to some people. And then after about a year or two, they really can't prove that it does anything or it works. Or you'll go to your group and say, hey, I saved you $5 million, or your patients are X% more healthy, and they're going, where? Show me the data. And you just don't really have it. So as organizations are being built, one thing we really talk to them about is focus heavily on intervention, of course, but how are you going to measure the impact to the patient? How are you going to measure that outcome? Is there a standardized test you can use today? Is there a PHQ-9 or a GAD-7, for example, to keep going with that one? Is there a way to capture patient-reported outcomes? Is there a PROMIS 10? Is there other types of institutional testing mechanisms? If not, can you create something that is believable and defensible to the purchaser of your service? And if so, fantastic. Then you can build a great big company and go. But too many times folks are not thinking about that early stage. They're just thinking about, I just created this really cool solution. And of course people want to buy it. It's my job to help challenge them to say, well, let's make sure that's true before you waste your own money, your own time, or worse, you borrow somebody's money and you can't pay them back either. So,
yeah.
So that may be a longer answer you're looking for, but there's a lot of things to think about out there when people are starting these new ideas. But I'm just so thankful. One thing I take a lot of comfort in is it's easy for all of us to kind of think through, hey, this is kind of how it is, not much to be done. I'm on the front row of this thing. There are thousands and thousands and tens of thousands of organizations popping up every day, not every day, but are active every day, trying to solve for everything you can imagine. And some of the smartest people in the world are at this thing every minute of every day. So the cool thing for you, for your age and to say to your career, how you're going to be treating patients, how you're going to be trying to solve these challenges in 20 years doesn't even exist today. And so it's going to be your generation that's going to help solve this next thing, as mine did for this last one. But in the end, I think technology is going to open up a brand new way. And you're going to look back 30 years from now and say, my gosh, how archaic were some of the things we're doing. This podcast will seem so crazy dated, but this is where we are today. But y'all's generation will be the one to actually take it and affect change in ways we can't even imagine today.
Yeah. And I'm happy that you said that, because it also kind of ports back to what you were talking about earlier, which is consistent research and challenging the status quo, which needs to happen on a daily basis, because that's how innovation is made. Indeed. And obviously evidence-based practices, like you talked about earlier, and being outcomes-based is really important, while also how can you continue to push the envelope forward?
Yes.
And that seems to be such like an interesting line. But it also makes me want to go back to healthcare and health insurance, more specifically, and demystifying health insurance, because I feel as though in general, Health insurance is such a big part of the equation as it pertains to mental health and healthcare in general.
Sure.
And it also is so confusing to all of us. And I'm speaking from a personal perspective because I'm like, I get the bill in the mail and I pay it. But also, I had to go to, I have Crohn's disease and I had to go to the GI the other day. And part of one of my procedures at the bottom of the form said, this procedure is, or what did it say? This doctor is financially incentivized to perform this procedure.
Right.
And I'm like, oh, yeah. I'm like, oh, that's interesting. I need this as of right now because I have to get, consistent checkup every so often. But also it is interesting that even from a insurance perspective, they're informing me of what's going on here. But there is such mystery of how insurance works.
Yeah.
So if you could give like a crash beginner course to some of this stuff, I think that would be really helpful for all of us.
Yeah, totally. Happy to. So here, we'll start with the way, so I mentioned 50% of Americans receive their health coverage through an employer, and that typically is delivered through some kind of an insurance product, right? So we'll break it down real easy. So there's kind of two ways in which insurance is built in this insurance-y world. So if I'm a large employer, say for the state of Texas, or my XYZ company, you name it, I have two choices. I can either be a self-insured employer or I can be a fully insured employer. And the difference between those, and these are foundationally important to eventually get to that letter that you read or the form you filled out. A self-insured employer basically means that I, as the employer, am going to pay for all the medical coverage for all my employees as it happens. So if you go to your doctor for your annual checkup and that costs $100, maybe you had a $20 copay, your employer's paying the other $80. That's how that works. And so in many cases, people think the insurance company is the one actually paying. The insurance company actually almost acts as like a third-party administrator. They're facilitating the claims. They're helping to build the network of doctors. They're answering your phone call when you have a question about your benefits. They're kind of the machine between the employer and the provider, but ultimately the employer is paying for that thing. God forbid you have a bigger diagnosis down the line or have an accident of some sort and you have a $100,000 medical bill. Well, after whatever your deductible is that you pay and your portion of it, it's not the insurance company that's on the hook for that in this model. It's actually your employer directly. And so a small company, imagine, let's say a 10-person company, one person gets a cancer diagnosis, that tiny little company is paying for most of that, and it's going to impact the cost for everybody else out there. It's not that the insurance company themselves are paying for that or raising rates, whatever. It's actually, they're a self-insured employer. It's exactly what it sounds like. The other side of the world is called fully insured. In that world, the employer tells the insurance company, look, I just want to write one check and you take the risk, insurance company, and I'm going to pay $1 million for my team. And if coverage comes in under $1 million, the health plan wins. If it's over $1 million, the health plan loses, but it's just who's going to hold the risk. And so in fully insured, an employer says, I don't want it. I will write you a big check, and health insurance company, you're in charge. Or in self-insured, the money flows directly back and forth from the employer. Does that make sense so far? Mm-hmm. So if you go forward, then a medical plan has to be established, which basically says your employer is going to say, hey, here's what we're going to cover. Here's what we're not going to cover. And then there's nuance under every single condition too on what level are we going to cover. Do we require an approval for this? Your doctor says, hey, you need knee surgery. Well, there's a medical plan that your employer has decided on that says, is knee surgery covered? Yes or no? Okay, let's say it is, but maybe it requires authorization. And so the insurance company will fulfill that duty on behalf of the employer, but ultimately it's the medical plan itself that the employer agreed to, which is dictating that. And so again, people tend to demonize insurance companies, and they play their part in things, don't get me wrong. But in many cases, the insurance companies are really just acting on the medical plan that the employer has put in place. You can make the same types of conversation like Medicare, Medicaid. There's certain things that are going to be covered, certain things are not. There's a pre-agreed upon pricing. And so what ends up happening is doctors and providers have to live within that. Or in some cases, you get a bill that says, hey, your insurance only covered this much, and I still need this much more money. Right. So all of that's based on a medical plan has said this is what we're going to pay and what we're going to cover. And then we go outside of that. The problem we have as patients is no one tells us this stuff. You go to the doctor's office and you read the form. Most people don't. Or even if they do, they have a hard time understanding it. And the doctor says, well, look, you're responsible for anything that your insurance won't pay. Well, the insurance says, hey, we think that knee surgery costs $5,000, but that doc feels like they need $10,000. they can try to come back after you as a patient. This is the only developed country in the entire world where we can bankrupt ourselves on medical things, right? And so the insurance companies tend to be demonized in many cases, but you need to look back and fundamentally kind of follow back to who's paying for the care and what is the medical plan that they put into place. And then the providers, one last challenge I'll mention in fairness to providers is they have no visibility in any of that stuff. So they're just trying to treat the patients in the best way that they can. And there's certainly some bad actors out there for sure, but the far majority of providers are trying to do the right thing, but they don't have visibility that your insurance only covered 40% of this procedure or 80%. They're going to send you for a scan down the road because they have good experience with this one imaging company. They don't know that that one charges 3 times more than the one over there, which, by the way, does the exact same thing, right? So you're seeing more and more solutions and more tools to help people kind of navigate their care, just so they can make the best decision on their behalf. But the problem is we're under duress and we're making decisions about our health at times when we're nervous about our health, and not everybody is incented the same, and not everyone has the same level of information. We try to make these choices, and it gets to be really difficult. Yeah. But insurance companies in general, they certainly pad a lot of cost. They require a lot of money to operate. They certainly put more money into the system. PBMs are a whole other conversations about prescriptions and what we pay for prescriptions in this country. So there's a lot of hands on a lot of pockets in our healthcare system, and it's a podcast for another day on how to try to solve that. Yeah. But at the moment, what the workaround there is, a lot of solutions and tools are being created, a lot of resources, and even government action. There's been legislation around transparency and pricing. You as a patient need to know before you go for that knee surgery, here's how much it's going to cost you, what your insurance is going to pay. Can you afford this? Are there other alternatives? It's getting better, but it's still just a mystery. I mean, it should not be that way. It's the only thing we purchase in our day-to-day lives. It is a complete mystery to us when we walk into it. Yeah. And so we have to enable better access to information for patients and providers. And that transparency though is happening, but it's just not happening fast enough. So yeah. I'm not sure that was very succinct at all, but
no, that was great. I think that was really great because any insight is better than what we're getting now, at least from my perspective as somebody who's going into that realm. And whether I am going to own my own practice or work for an agency or go into the community level part of, that might be more grant funded or things along those lines, I think it's still important to understand how and demystify how insurance works, because that's how you get compensated.
Yeah, and you should think, and the thing you'll have to think about, like every provider does, is what type of model do you want to live in. So one reason why value-based care is having more and more of a moment is a lot of providers rightfully are saying, look, I don't want to practice medicine in a fee-for-service model because the paperwork and the coding. Every time you go to a doctor, there's 40 codes that get generated that feed in that eventually lead to a payment. And it's an overwhelming burden for these practices, for these doctors' offices. All of that is unbelievably challenging. So you're seeing, and on top of that, the medical plan design that I mentioned is also dictating the way in which that they provide care. Now, the positive side of that is most medical plans are built around evidence-based medicine. And so on one hand, it's great. It's a lot of protections. On the other hand, though, you mentioned earlier, we talked about flexibility as a provider. It kind of eliminates all that, right? Or it takes it out of a scenario where you want to try something, but you may not get paid for it. And so you're seeing a lot of providers leaving the traditional world. So it's for sure in primary care. So we have a massive primary care shortage in this country, and it's only going to get worse because more and more doctors are like, you know what, I'm going to leave the traditional world and I'm going to go, and they call it concierge medicine sometimes, or private pay. And in that scenario, you pay me, I'm a patient, I pay my doc, I pay him $1,400 a year, and he's my doctor, and everything he does for me is included in that $1,400. It's never going to be billed to insurance, but I get kind of more one-on-one care that way. But the doc is basically saying, look, I don't want to be in this fee-for-service world anymore. I think I can provide better care over here. But most of our healthcare comes from insurance. It puts an additional financial burden on patients, so it tends to focus more on patients who can afford to pay for it, which is not everybody. The advanced primary care concept I mentioned earlier, it kind of rides in between, right? It can be subsidized by an employer or by a Medicaid or a Medicare, even though it's not insurance. They can select to pay that $1,400 a year, whatever it may be. But in that scenario, that provider is kind of taking on a bit of a risk. So imagine you as a provider to say, look, I like that model better where I deserve to make a living. I'm going to make my $1,200 a year on a patient, and I want to be able to be super creative in the way I treat that patient. But if those interventions cost you more than $1,400 a year, you're going to lose money as a provider. You're going to go out of business. But on the flip side is, if you can treat that patient and get them healthy for $300 a year, you get some upside on their outcomes. So, you can decide whatever flavor you like or whatever you feel like feels right for your heart. But at the end of the day, I think as a provider, we just have to continue to find financial models that allow you to practice medicine and treat that patient, but also continue to rely on evidence-based medicine to ensure that we don't have people abusing the system, which is how we got to a lot of this problem we're in today.
Yeah. And thank you for that. Because I've heard so many mental health providers that are now, I guess, separating themselves from the insurance model and just doing private pay,
100%.
Which makes sense in accordance to kind of what you told us, because they don't, I guess, see the benefit of, I guess, following in those footsteps and doing it differently.
And the reimbursement rates are going to be lower if you go through an insurance company, because there's so much other cost. They may say, a United Healthcare or a Blue Cross or Cigna, or any a bunch of them, so no one thinks I'm singling them out. But in the end, they say, hey, Cody, for an hour-long session of your time, our negotiated rate is $80. And you may look as a provider go, I can't operate a business as a provider, and I can't create adequate care for my patient for $80. So I think it needs to be more like $120 for that hour. And if you can't get that the insurance side, then that's what's happening. Is people going, you know what, I can't provide the type of care, and I can't run the kind of practice that I want to run off of what they're able to pay. So I'm going to step outside of insurance. And again, some people can afford to pay that. Most people are stuck within an insurance plan. So it limits the number of patients you can seek, but it also then creates a little bit of a class system too, which we want to try to avoid, right? And it kind of creates, it's more of a concierge type of benefit. And it's just one of the challenges I think we're in the middle of right now that we're trying to solve for.
Yeah, because when I think of community level solutions to all of this, which is what we need, we need no one to be left out.
Exactly.
And if more providers are going more towards, I guess, a wealthier clientele, because they have the money to be able to pay the $120 to $150 to $200 an hour for mental health care, what happens to those that are only being compensated at the $80 rate? But that leads me to ask, do you know of what goes into that reimbursement number? How does that kind of, how does a company say, yep, you're going to get $80, and the person, the provider's like, it's supposed to be 120, and they're like, nope, 80, that's it. How does that number come up?
Great question. So if you think about back to the example I gave earlier on, who the payer of healthcare is in this world. So let's say, stick with an employer example, or a Medicaid or Medicare, however you want to look at it. Let's say it's employer here. One reason why they do hire an insurance company is they need someone to go out there and identify all the providers, right? So if I own a bakery here in San Marcos, Texas, I don't have the ability to go out and figure out who the cardiologists are, the mental health providers, and everyone else in this area, and then go one by one and negotiate. Cody, you're a cardiologist in San Marcos. How much are you going to charge for these 55 services? So they look to the insurance company to go do that. And they're great at that, right? And they've already gone out and they put all these docs inside their network. So you've seen that before. And then part of that deal is they also then negotiate rates with those providers. They're going to say, hey, look, we're going to put you on our network, but for these 55 things you do, here's what we pay for each of them. Because what they're going to go back to the employer and say is, look, we're going to help kind of control cost. And we're going to negotiate the best possible rates for you, which as the purchaser of healthcare, you're like, fantastic. What's been missing in our world, though, back to our conversation about value-based care, is there hasn't been a lot of outcomes associated with that. So we're going to pay that, but what if this doctor doesn't do a good job, right? What if they don't get the patient healthy? What if the surgery I had requires a revision or a readmission to the hospital? So more and more, good news is health plans, insurance companies have also now been created additional incentives based on outcomes. So they might have a second tier of doctor who actually do make more money. So maybe the base rate's the same, but if it's a value-based model, maybe they make more based on the health outcome. Or maybe they're kind of in a higher tier, so they're able to ask for more money on that side. Or maybe you're a specialty, right? That you're the only guy in the entire state of Texas that knows how to do this one thing. You're going to charge more money for it and probably get it. And so at the end of the day, that is kind of how the rates are set. The health insurance companies are working with the providers. Their goal is to get the price as low as possible for their client, which is an employer in this scenario. But they also are putting more and more quality outcomes demands on those providers as well. So it is trying to find a balance. it's not there. But ultimately, the providers in many cases get squeezed, because if you are a provider, and you will be, and you want to be inside of a network of a health insurance plan, if you don't accept that rate that they give you, then maybe you have to work outside of insurance and you're no longer on the provider directory. That's how you get a lot of patients, right? People say, I'd love to come see you, Cody, but I have insurance through my employer and you're not covered there. So if I hire you, I have to write a check for all of your services and I can't pay for that and my insurance. And so that is some of the challenges. And it's the Sophie's Choice. When I was at this company, Folks Health, I mentioned earlier, we were a specialty provider focused on a pretty specific segment of people. And they were trying to put us into the tiers of just a standard telemedicine doc. It's like, no, we're different. We have higher level of education, specialties, expertise, et cetera. We think we should be up here. And it's a negotiation. And you can have the negotiation, but ultimately the providers have to be able to make sure they can make a living. They have every right to make a living. And you're running a small business if you run a practice. And if you're in a community organization, you're receiving funding from, maybe it's through Medicaid, right? So same types of things. You have to make sure you can run that community organization, run your interventions through what Medicaid might be willing to pay you. It can be challenging, right? And it might limit the number of things you can do. And so this is just, unfortunately, kind of the funding mechanism that's very unique to the United States that we built. And in short of tearing it down and starting over again, we're trying to constantly patchwork this thing. And hence, that one I'll mention for the last time, but this is where we hope value-based care can work within some of the existing structures, but really put more and more incentives towards patient outcomes of all shapes and sizes to ensure providers can make money, but are also incentivized to try to get patients healthier.
Yeah. Thank you so much for that. I feel personally that I've needed that answer.
I hope I didn't make that muddier, but
No. I don't think that you did at all, because this is such a big question that seems to be, again, to use the word, mystical in regards to, you just take insurance or you don't take insurance, or you might use a community level organization that gets most of their funding from grants or donations or things along those lines, which is also amazing in there. But it's part of the conversation that I don't think we really talk about, especially from a student perspective and from a research center perspective. We want to know how the organization and how our community is getting access to the care that they need to get access to, or where the holes are or the ball is being dropped. So I think that's amazing from my perspective. We're getting close to the end, and I would love to end on one question for you, which is we talked a lot about the future. We talked about insurance structure, AI, things along those lines, organizations that you're excited to work with. What are you most excited about as it pertains to the future of all the things that you're working on, or the future of what you see coming down the pike? Like, what are you most excited about in regards to healthcare in the future, specifically for mental health care?
You, in your generation, right?
I'm flattered.
No, it's true. I made the comment earlier, which is, I'm very fortunate from the chair that I sit in that I have visibility across the country and really across the world. There's a lot of those founders I talk to are actually, many of them are from all over the world, and they'll reach out to me to learn more about the U.S. healthcare system, or just to say, hey, here's our idea. What do you think? But there's so many organizations that are trying to solve all these problems. So I think it's easy to repeat myself a bit, but it's easy to sit back and think like, well, it just system sucks and this is the way it is. I can tell you that there are tens of hundreds of thousands of people in this world trying to solve not just the big problems, but over the last 15, 20 years, you're seeing just people trying to solve micro, very hyper specific challenges. Just one quick example to highlight the point. I talked to a founder recently who is creating a wearable device which is focused on creating a neurological baseline for a patient utilizing voice. So they've been able to tie voice quality back to neurological function, and they'll create a baseline over time. And their hypothesis is that they can begin to identify neurological decline years before your wife goes, is everything okay? And so imagine a scenario where with Alzheimer's or dementia that you can actually identify the decline has begun before I feel it, you feel it, anyone else feels it, and you can begin an intervention that much earlier. So it's just an example of there's people that are trying to solve from your generation that are young, at least younger than me, trying to solve things that are just amazing that could not have existed 5 years ago without AI or without technology, certainly not 20, 30 years ago. And so I'm super, super encouraged by that and just how much passion is out there in the space. And the good news is there's a lot of dollars and funding which wants to make these people be successful. The challenge ultimately is how do you bolt it on to this very clunky healthcare delivery system we created for ourselves in this country. But I am encouraged on that side.
Yeah. Well, you make me excited about it too, because I know that there's space to innovate. There's space to do research, to, I guess, be pushing the envelope.
100%.
And that's from what I hear from you. Like, that's what it's going to take, is us to continue to move forward and take into consider some of these things like incentive-based care, as well as not tearing down the system, but potentially bolting onto it in ways that have challenged the status quo. So yeah, I appreciate you coming down and talking with us. This is great.
Thanks for having me.
We usually end with you kind of going through how people can get in contact with you or who you're looking to connect with. So would love that. Like, what's a good way to get in contact with you if someone's interested?
Sure. Probably the best way, just outreach directly. So Brad at jb-advise.com is my email. And also LinkedIn's an easy way to find me. I actually don't even have a website. I've been lucky enough to have kind of just truck along below the radar a little bit. But I think the types of organizations I'm excited to work with, a lot of what I've mentioned here today, but at the local level, as we think about, like, say, South Central Texas, those are really continuing to look at ways to enhance outcomes measurements, value-based. I have a pretty incredible team that I work with. I haven't had a chance to talk about today, and that we can bring to bear that really brings a wide range of experiences. So just those are looking to try to create some fundamentally different types of care delivery models, and or weaving in a lot of the digital health and some of these things are kind of maybe outside the local area into their solutions. Would love to chat about that. But mostly just, I want to help affect health here in South Central Texas as well as the country. But my passion is really right here where we live. And whether it's mental health or physical health, I'm just lucky to be part of the community.
Great. Awesome. Thank you so much, Brad,
thanks for
joining
having me,
us.
Cody. Appreciate it.
Yeah. This podcast was presented by thecentralstate.com. Thecentralstate.com is a consortium focused on improving resilience in Central Texas by using evidence from research to improve human and community health. This website highlights health and research data by county and opportunities to find funding and resources for mental health programs in our area. Additionally, there are interactive calendars that keep you up to speed regarding what is happening right here in Central Texas.